Good evening, ladies and gentlemen. Welcome to the third webinar of the 2024 Back to Basics series. Today's webinar will be on Fundamentals of Contrast-Enhanced Mammography. I will moderate this session with Giovanni Irmici from Milan, Italy. And I am Melis Baykar Ulusan from Istanbul. And we will with dear Mark Lopes, Dr. Mark Lopes from Netherlands. And please don't forget to fill our survey at the end. So you can claim your CME credits for this webinar. 1 CME credits it will be. And this webinar is sponsored by Bayer. Thank you. And I will pass the mic to my moderator colleague, Dr. Irmici.
Hello, everyone. Thanks to Yosobi Young Club for this kind invitation. Today, I'll present Dr. Mark Lopes. He's a dedicated breast radiologist since 2011, current chairman of the board of the Department of Medical Imaging at the Medical Center in Sittard-Geleen in Netherlands. He's a board-certified clinical and screening radiologist with an extensive experience in contrast-enhanced mammography. He was one of the first to introduce CIM in the Netherlands in 2012, and has been promoting the implementation of CIM in everyday clinical practice. So after this presentation, who better than Dr. Lopes to tell us about this technique that is gaining more and more space in our everyday practice. So I give the mic to Dr. Lopes.
Thank you, and good evening, everybody, or good afternoon, or good morning, wherever you are in the world. First of all, my apologies for my slightly nasal tone, because I'm recovering from a big flu, but I'm happy to be here, recovered just in time to give you a presentation. These are the presentations I personally like most, because it's really going back to the basics, and repetition is the mother of all learning. So it's very good to have these sessions, and hopefully I can explain to you some of the basics of contrast-enhanced mammography in the upcoming 40 to 45 minutes. Now, this is always the exciting part, the sharing of the screen. And if everything's correct, now you see the title page of my presentation. If not, please, somebody let me know, but otherwise I will continue. First of all, my disclosures. It's not really interesting to read, but it's always part of every transparent presentation, as you know, of course. While starting to talk about contrast-enhanced mammography, I always want to take one step back to regular full-field digital mammography. Full-field digital mammography is still a very good basic breast imaging examination. It's easy to perform, it's widely available, it's cheap. Yes, it has the discomfort of the breast compression, which is always a little bit of a disadvantage of regular mammography. And there's also one other disadvantage of full-field digital mammography, and that's the fact that the sensitivity and the specificity is highly dependent on the density of the fibroglandular tissue. As most of you will probably know, we divide the density categories into 4 categories, A, B, C, and D, or 1, 2, 3, and 4, whichever you prefer in your reporting. And when you look at the example in on the left side of the image, you see what they call a fatty breast. The breast contains only small strands of glandular tissue and contains a lot of fatty tissue, which makes the background dark gray and much easier to depict tumors on those kinds of images. In those cases, that leads to a sensitivity of 87%, which is quite high for any diagnostic test. But if you go through the images to the right, and in the most right picture, you see what they call an extreme dense breast, you see that the sensitivity drops to almost 63%. And when you consider that flipping a coin is, in theory, a sensitivity of 50%, you can see that this always feels a little bit awkward of performing a breast imaging examination when you know that in some women, the chances of finding a cancer are only slightly higher than flipping a coin. So from history, there have been many attempts of increasing the diagnostic accuracy, be it with ultrasound, MRI, tomosynthesis, and contrast-enhanced mammography is one of the new additions that we have since 2012. And I myself started to implement contrast-enhanced mammography in January 2013 by looking at women recalled from screening using contrast-enhanced mammography. And I will go into that a little bit later. Now, what does a typical contrast-enhanced mammography image look like? It looked like this. You have here only the MLO views being presented because of the size of the slide. But of course, you always have 2 views per breast. So we always acquire a CC view as well. Sorry. In the center part, you have what they call the low energy images, which resemble a normal mammogram, like in everyday clinical practice. And we have an additional set of images that is called the recombined images, where we can appreciate areas of contrast captation. Now, areas of contrast captation are suspicious of breast cancer, but are not really a proof of breast cancer. Some benign structures like fibroadenomas can also show some enhancement at certain times, and there can be a reason for false positive even in contrast-enhanced mammography examinations. But I think here in this very clear case, you see a very visible mass in the left breast. That's not too difficult to detect. But I think the multifocality of the breast cancer, which was detected here, can only be appreciated the best if you look at the contrast-enhanced images. And in this case, you even see that the central part of the mass is lacking some kind of contrast, which we recognize when we have experience with breast MRI examinations. So even here, you could suggest that there is some central necrosis within the tumor itself. And that's probably likely to be an aggressive tumor like a HER2 positive tumor or a triple negative tumor, which was the case in the end in this very young woman. Now, first of all, how do we get these kinds of images? So what's the imaging protocol? At first, you need to introduce iodinated contrast agents. So we know that they are associated with contrast-induced nephropathy and hypersensitivity reactions. So we need to screen for that. It's sometimes a little bit different in parts of the world how they tackle with the use of iodinated contrast agents. Some have some local guidelines that they adhere to. But it's important to know that the rules, in fact, are the same for contrast-enhanced examinations when you use, for example, CT. And also dealing with the hypersensitivity reactions is similar to what we have been used to doing for years in CT examinations. So the easiest way to deal with the use of iodinated contrast agents is just apply a protocol that you're used to when you look at contrast-enhanced CT examinations. We always tend to inform the patient about the procedure, not because the risk is very high, but it's a little bit different. Many women are used to getting a normal mammography, but when we all of a sudden decide to use an intravenous line and use contrast agents, and the whole procedure is sort of taken up a notch in difficulty, women could get a little bit anxious, and we just try to explain them the reason why we're doing this additional examination and also what it entails so that they are prepared and they know what's going to happen. You place an IV catheter. We usually prefer to put it in the antecubital vein, and you need to check the patency with a simple saline flush to check whether the catheter is placed within the vein. We administer the iodinated contrast always using an automated injector, followed by a saline flush just to clear the lines and have all the contrast inside of the body. But actually, the use of an automated injector is not a prerequisite to use contrast-enhanced mammography. It eases your life because you administer quite high volumes, up to 100, sometimes 120 cc's. Which means if you would do it manually, you need these big syringes of 50 cc's. And if you need to squeeze them through small intravenous catheters, it's quite strenuous. And it's okay to do it once, but if you, like us, do 3 to 5 examinations a day, your technicians become tired and annoyed. So the use of an automated injector is just more easy in everyday clinical practice, but it's not a timed examination. It's not a dynamic examination, so it's not really relevant to have it or not. It makes your life easier, and the only time that we do a manual administration is when the automated injector has a technical error or whether it's in maintenance. The contrast dose should preferably be over 300 milligrams per milliliter. That's the most often used dose that you see in literature. Some use 300, 350, 370. There's not much information regarding the optimal dose of contrast-enhanced mammography, but roughly said above 300, you're doing it correctly. 1.5 milliliters per kilogram of body weight is the rough estimate that we use in our practice. And we have a cutoff of about 100, and in our institute 120 cc's of volume, which is quite high when you compare it to CT examinations. And in the endpoint, the take-home message here is that we can still try to study contrast dose optimization studies. So if anybody is up to doing research, I think that's really a gap in knowledge to see if we can reduce the contrast volume a little bit. The automated injector speed is 2 to 3 milliliters per second. It's just standardization of your protocol. But the most important thing is that you need to wait 2 minutes before you start any acquisition of the mammographic images. The contrast needs to circulate throughout the body, and you should start not sooner than 2 minutes and not later than 3 minutes with the first imaging acquisition. And please do your the examinations in the order that you're used to. When we first started with a rather smaller group of doctors doing contrast-enhanced mammography, there was this thought that we needed to do the affected site first. The reason behind it is that you would need to wait 2 minutes to have the peak enhancement of your tumor. So then you would get the best recombined images of your tumor at the peak of its enhancement. However, this always suggests that you're going to encounter something on a known side of the breast. But right now, we're even looking at doing contrast-enhanced mammography in screening populations, which have a very low chance of encountering breast cancer. And we even don't know where the cancer is going to show up. So it's much more easier for your everyday practice to just perform your mammographic positioning in the way you're always used to. When you change the order of image acquisition, your technicians become a little bit anxious. They become stressed. They are afraid that they cannot finish within the 10 to 12 minutes that they need to work within. But if you have a 2 minute delay before you start and you have experienced technicians, it's very easy to complete the examination in 6 to 8 minutes. And if you encounter also count in the administration of contrast and the placement of an IV catheter, the whole examination is up to 15 to 20 minutes in total when you have an experienced staff. Special views can easily be acquired within that time frame as well. And we always recommend just do not remove the IV catheter until the entire examination is done. You can have slightly delayed hypersensitivity reactions, and you can always do the ultrasound, the biopsy, talk to the patient. And before you conclude all of your diagnostics, it's easily 15 minutes or 20 minutes down the road, and then it's a safe period to remove the IV catheter. Now, why do tumors enhance on contrast-enhanced mammography? That's actually not very specific for contrast-enhanced mammography, but we use it in a lot of oncologic imaging and in a lot of different modalities like CT or MRI. The reason behind it is that when tumors are very small, they get their nutrients from direct diffusion of the direct environment. When they grow, they lack the nutrients and they become hypoxic. And when they become hypoxic, they tend to excrete vascular endothelial growth factors. Now, these diffuse into the direct area of the tumor and sort of stimulate newly formed vessels to grow towards the tumor to the highest concentration of these growth factors. So in general, the tumor sort of makes its own vascularization to have another supply of nutrients again. However, these small vessels in a process that is called neoangiogenesis are very rapidly formed, and they lack tight junctions between their cell barriers, and they're sort of leaky to contrast-enhanced contrast material. This could be gadolinium-based contrast agents, so we could use MRI to detect contrast enhancement. But if you use iodinated contrast, you need to use, of course, an X-ray based examination. So there is a time frame in which the contrast is sort of seeping into the tumor interstitium. We are able to detect it there, but there's also a time period where we excrete the contrast, the levels in your bloodstream go down, and then you have a washout again from the tumor interstitium back again to excrete it from your body. Now, we know that we have a certain time frame in which we have a little amount of iodine within the tumor, but now we need to find a way to image that. And the way we do it in contrast-enhanced mammography is by dual energy mammography. Now, in general, we do mammography at 22, 25 kV, which is the green dot depicted on the x-axis. That's where the low energy image is also acquired. Now, from that point, if you go up on these bars, you can see that the difference between the attenuation coefficient of, for example, breast tissue or breast fatty tissue, but also breast cancer tissue is very small. In this picture, these lines go down because you see that when the kV goes up, the X-ray spectrum gets harder and much more passes through the body and is not being absorbed and does not allow us to do any kind of contrast generation within images. You see that within the breast with these structures, the differences are there, but they are very small. But they're enough to depict them sufficiently on a mammogram because we always use some post-processing to enhance the differences a little bit more. Now, with iodine, something strange happens, which you can see in the orange line. We have what they call the K edge of iodine, which is exactly at 33.2 kV. And there you see that the curve shifts up a little bit and then follows its normal path again when you increase the kV levels. You can imagine that if you have a breast cancer, which is depicted by the gray line, and you add some iodine to it, that gray line will also show this phenomenon and sort of separates itself from the dotted lines again. So you are able to have a contrast between breast tissue and breast fat tissue, plus the breast cancer tissue. In summary, when you look at the low energy image, you can make a distinction between cancer tissue, breast tissue, and breast fatty tissue. And when you use a higher image spectrum, you can make a distinction between breast cancer tissue versus breast tissue plus breast fatty tissue. And that's the reason why we make a subsequent high energy image directly when the breast is still compressed within a matter of seconds. And this is in fact how it looks. We have a low energy image. Again, the settings are the same as a normal mammogram. So you get the normal mammogram in every aspect. But then again, you also get a high energy image. It's a high energy level, so a lot of it passes through the breast, and this looks like a little bit of overexposed image. However, if you look carefully, there is some information in there. And you already see here, when I change the window level settings a little bit, that there is some information regarding contrast within that structure of this image as well. Now, what the post-processing system does is make a subtracted image and also use a dash of post-processing as well to create the recombined images. So the term subtracted images is not accurate because it's not image 1 minus image 2. It's actually the basis of the algorithm, but it's also a little bit more of logarithmic post-processing as well. And that's why they call it the recombined image, in which we can see areas of contrast captation. Now, as a radiologist, we only see the low energies and the recombined images because the high energies are not of diagnostic quality. When you use contrast-enhanced mammography, you should also be aware of some very typical artifacts. And these artifacts are mainly seen in first-generation machines. We have the breast-in-breast artifact, which is sort of a loosened line at the periphery of the breast. We can have some simulation of skin enhancement, so the skin line artifact, but there's no skin thickening there on the low energy, so it's very easy to see that. We have some motion mismatches during the image acquisitions, which can lead to ripple artifacts. You can have calibration artifacts. Sometimes you have service technicians working on your system and they use phantoms and they can cause a little bit of calibration artifacts when they're not being properly recalibrated after their service. And you can also have contrast splatter. Now, you can see here on the left an image example of contrast splatter, and you can imagine that on the low energy images, this might look like microcalcifications in a small cluster. However, like I told you just several minutes ago, it's in the basis of subtracted image. So when you look at calcification, they should turn up black on a recombined image, especially small, minuscule calcifications like the one we are looking for as a radiologist. They turn up black on your recombined images. If they show up white, like here, you should consider the possibility of contrast splatter, and you should consider rinsing off the breast, cleaning the detector, and acquire the image again within the time frame, of course, that you're using for contrast enhanced mammography. But when you see one or two of them, they're very easy to recognize. Don't worry. Now, another thing that's really a contraindication for contrast enhanced mammography is breast implants. They give large artifacts surrounding the implant. It's just because there's another kind of material within the breast, and the system cannot cope with that really that good. Some hospitals still do contrast-enhanced mammography. That's fine, but you get very big artifacts. And remember, we still have MRI. It's not forbidden to do MRI. And I think the benefit of doing MRI with women with breast implant is much bigger than doing it with contrast-enhanced mammography. On the other hand, we have some things sometimes inside our body that is not allowed to be easily entered in the MRI. Of course, cardiac devices, when you need to do it, you can use them within MRI. They're sometimes MR capable. But here you can see, without any risk of having an error within your pacemaker or any other cardiac device, you can quite easily do a contrast-enhanced mammography. And even if you have jewelry, piercing, you name it, it's very safe to do contrast-enhanced mammography instead of MRI. Now, one of the first things that we're asking ourselves is, are we not giving too much radiation since we're doing double image acquisitions? Now, in one of our first studies with Cecile Jeukens that we did in Maastricht when I was working there, is using the first generation of system by GE Healthcare and comparing the low energy images, the high energy images, and the total of the two combined, and compare them with full field digital mammography. And of course, the radiation exposure depends a little bit on the breast thickness. It becomes bigger when your breast thickness is increased, of course. In the end, we found that approximately the radiation dose is increased by 80% when you compare it to a normal mammogram. Some results note 20%, some may 50%, but I think the most realistic papers that are out there on this topic is somewhere between 50 and 80%. And it depends a little bit on the population that you study, the settings that you use, and what kind of generation of system that you use. Because, of course, the technical developments are not standing still. They improve even at this area as we speak. Now, you should also ask yourself, is this harmful? You should still remember that mammography has a very low radiation exposure. And even if we increase it by 80%, that still means that it's a very low radiation exposure. For example, if you look here at this image, which compromises the lifetime attributable risk factor, so the chances that you get breast cancer due to an image exposure or that you die of it, is very small. For example, look at relatively young women with the age of 40. When you look at full field digital mammography, which are the red lines, you have an incidence of approximately 1 in 100,000 when you do an image exposure in these rather young women. It's doubled. You can say it's doubled to 2, but it's still 2 in 100,000 the risk. And this is a hypothetical risk based on all kinds of modeling that we're used to doing in these questions. Now, if you compare it with the natural incidence or the risk of dying of breast cancer in the general population, it's nowhere comparable. So yes, we still need to adhere to the ALARA principle. I fully agree, but we should also not be too afraid of using the extra radiation when we have a very valid reason to do contrast-enhanced mammography. Now, my dear colleague from Italy, Alessandro Cossi, did a very nice review quite recently on where we stand with contrast-enhanced mammography, and even divided it between very specific questions, like looking only at the recombined image or looking at dense breast. But when you look at the green bars, which is sort of the summary of all, you see that the sensitivity of contrast-enhanced mammography is up to 95%, with a very good specificity of up to 81%. And these are actually numbers that we're used to reading about with breast MRI. So it's up there with breast MRI as a competition. Again, it's not a replacement for breast MRI, but you can be smart in using contrast-enhanced mammography. Where can I use it and where do I still need breast MRI? And these results are also reflected on the right side with the ROC curve as well. Now, the comparison with breast MRI is an obvious one because we know that the underlying principle is roughly the same. We also look at neoangiogenesis and enhancement with breast MRI. So one of my former PhDs, Lidway Neter, did a systematic review on all available literature, focusing on women that underwent both contrast-enhanced mammography and MRI. And the summary here is that you see here quite nice sensitivity numbers of 96% and specificity of 77%. And when you compare it to MRI, it's actually the same. There are some reviews out there with a little bit of different end results, and this is all about looking at what kind of inclusion and exclusion criteria they use. Of course, you can be a little bit strict, a little bit more liberal, but you always should be very critical in reading and how to interpret your results. They differ a little bit and you can have your own opinion about it. But I think the most important part is that at this point, with the limited available evidence that we have so far, is that sensitivity and specificity of contrast mammography and breast MRI seem to be on par, but we still need to have a lot more data to draw any definitive conclusions on this topic. Now, we also have potential indications for contrast-enhanced mammography, and these are roughly the indications that we in our institute use contrast-enhanced mammography for. We have the preoperative staging. We have evaluation of women recalled from breast cancer screening. This is the population that I started with doing contrast-enhanced mammography. Problem solving inconclusive findings on mammography or ultrasound. We even do it in response monitoring of breast cancer patients treated with neoadjuvant chemotherapy. Since October last year, we are happy to also have the ability to do contrast-enhanced stereotactic biopsies. We have evaluation of women with prior to history of breast cancer surgery, which is a very specific topic of some groups in Spain and Australia with very interesting results. You can have it as an alternative to breast MRI when you are claustrophobic. Evaluation of women with Cup syndrome. I was always taught by my professor, Carla Buttes, that when you have a woman with cancer of unknown primary, you do a mammography. If negative, you should do an MRI. But if you know that the sensitivity and specificity of these techniques is on par, why not do immediately a contrast-enhanced mammography? And of course, when breast lesions are detected on other imaging modalities, when we already see an ugly lesion on a chest CT, like we saw a lot on the COVID period, we immediately do contrast-enhanced mammography to already start the preoperative staging as well. Now, about preoperative staging, you can talk about how big is the tumor within the breast, so the intramammary tumor staging, but also the axillary staging and the internal mammary lymph node staging. But here I want to focus on the intramammary part, and the other parts you can read in my review that I published in 2021, why we still could do contrast-enhanced mammography for this indication. Now, when I teach residents how to tackle the preoperative staging, I always say begin big and work to smaller parts. So at the beginning, is it the left or the right breast? Which quadrant is it? The descriptors are the things like masses or asymmetries or anything that we knew from the Biots lexicon. Then the most important part is how big is your tumor in size, millimeters or centimeters, whatever unit you would like to have. But also important is to see whether there are multifocal lesions or multicentric lesions or even contralateral lesions. That's the main reason that we do preoperative staging as well. Now, Eva Fallenberg, in one of the first publications on this topic, already showed that the size estimation of contrast-enhanced mammography detected tumors and MRI detected tumors is roughly the same. You can see that these scatter plots are quite nicely in line with the sizes that we found on pathology. And this is a study that we sort of repeated some years after that. But I like to use these, what they call Bland-Altman plots. And for those of you who aren't familiar with Bland-Altman plots, I will just quickly go through them because I have several others which I would like to share with you as well. So on the x-axis, you have the mean diameter of the contrast-enhanced mammography and the histopathology. So 0 to the other side is a small tumor versus a large tumor. Now, the important thing is on the y-axis, you have the difference between the size estimates. So for example, if it's 4 centimeters on your contrast-enhanced mammography and 2 centimeters on pathology, your number on your y-axis will become 4 minus 2 is 2. And you can see here that as long as you're close to 0, there's actually no difference between your size assessments and you have the tumor that is accurately measured on your imaging modality. So the closer your dots are to the 0 line, the better your technique is. And the dotted lines are sort of the bandwidth that you need to work with. Now, you can also explain it as a mean difference. And you see here that in our study, the mean difference was approximately 0 millimeters in contrast-enhanced mammography and a little bit of an overestimation on breast MRI with 2 millimeters. But these are very small numbers. And when you consider that the surgeon will always take a safe margin when they operate, these are non-relevant differences, I think. Now, you could also argue, well, invasive lobular carcinoma has always been the terrain of breast MRI. When we look at invasive lobulars and we want to express the size, we tend to use breast MRI because it's a little bit more like an architectural distortion or asymmetry, and the mass shape is less present in those kinds of tumors, and it's much more difficult to appreciate the true tumor size. Now, with 3 different institutes, the Maastricht University Medical Center, Laurentius Hospital in Roermond, and our own Zuiderland Medical Center, we retrospectively looked at all cases that we did with invasive lobular cancer, that we had with contrast-enhanced mammography, and that we had with MRI. Of course, with MRI, a lot more numbers, but at least when you look at these results, you see again, when looking at the mean difference and comparing them to MRI, you see that these are roughly the same. And if I go back, especially below 3 centimeters, the accuracy of these measurements is quite good. When the tumor becomes bigger and more speculated, it becomes more difficult to measure it. And what they call the random error increases a little bit. So there's a little bit more risk that you have the wrong estimation. But again, if you look at MRI, the same phenomenon appears on MRI. So from a practical approach, what we do in our hospital is that when we have a contrast-enhanced mammography, and a size measurement, and it turns out to be an invasive lobular carcinoma below 3 centimeters, we say that we don't need an extra MRI. If we have a tumor that is bigger than 3 centimeters and the patient wants breast conservative therapy, that's another condition that we need to, of course, ask ourselves. Then we do an additional MRI sort of to confirm the results that we might have seen on contrast-enhanced mammography. Now, there's also a thing like multifocal disease and contralateral disease. And in general, here you see that the sensitivity of detecting multifocal disease is a little bit higher on the MRI side, also for the contralateral breast cancer. But you also have a little bit more chance of having false positives when you use MRI. And when you look at the balance between those two expressed at the diagnostic odds ratio, it's a little bit in favor of contrast-enhanced mammography. So when you use MRI, yes, you tend to find a little bit more cancers here and there, but on the other hand, you also run the risk of having false positive. And that's the balance that we need to figure out. What kind of tumors do we see on which kind of imaging modality? This is how it looks. This is an image example of a woman who was recalled for a suspicious mass on the right. You can see it now quite nicely, but not seen on the low energy mammographic images was a small enhancing mass on the left side, which you can see quite easily on the contrast enhanced mammography images, but also on the MRI images. Here again, you see a small enhancing mass in the central part of the breast, and you see actually the same appearance on the breast MRI. So it looks rather the same that you are used to looking at in breast MRI. Now, again, where do we still need to do MRI? I think with implants and things that are just difficult to capture in the mammographic field of view, like being close to the chest wall, on the medial part of the breast, or high up in the axillary tail. That's where I think the strength lies for breast MRI. Also, the use of magnetic localizers, which is a research topic that we're exploring in our hospital. We tend to use, in the early years, we tended to use wire localization. Then we switched, a lot of Dutch hospitals switched to the use of radioactive iodine seeds, but they're radioactive, they come with a lot of administrative burden, and an alternative might be magnetic seeds. However, they cause susceptibility artifacts on breast MRI, so you cannot use them when you're using response monitoring and breast MRI. But contrast-enhanced mammography could be a nice alternative because there's no reason here on the green example you see such a magnetic seed. There's no image distortion there at all because you don't use any magnetic tools in this image. Now, the way we do it in the Zuiderland Medical Hospital is like this. When we have, in our hospital, I need to say that we have 24-hour diagnostics. and we rely heavily on contrast-enhanced mammography. So this is a case where a woman comes in on Monday morning with just one cancer, and we need to do a breast MRI because she has dense breast or anything, but we still only find one cancer. So we do the mammography or a tomo, we do an ultrasound, we do the biopsy, and the next day during our lunch break, we have the MDT meeting and we decide this is a cancer, but we still need to do an MRI. So with any luck, 5 days down the road, we get the breast MRI. We see that's a unifocal lesion. On day 8, she comes back to the MDT and we have the results and the treatment plan in 8 days completed. Now, with contrast-enhanced mammography, we would immediately see that's only a unifocal one-sided lesion. We could do that biopsy and we have the results on day 2. In comparison, when we have a occult contralateral breast cancer as a sort of virtual patient, probably the route will be like this. Again, we will decide on day 7 that we do the breast MRI, and oh my God, we see a lesion on the other side. So she comes back for a targeted ultrasound, we detect it, we biopsy it, and then in the end, we're at day 10 in the afternoon, when you do it very efficiently on day 10 in the afternoon, that you have the final diagnosis. Now, again, when you do contrast-enhanced mammography at day 1, you would immediately see that's a bilateral cancer, and you could immediately do 2 biopsies in both breasts. And again, you would have the final results completed in day 2 in the afternoon. This, of course, is not always the case in every patient, but you can see how you can use contrast-enhanced mammography to your benefit to speed up your workflow efficiency a little bit. Now, regarding inconclusive findings, this is, I think, a nice example of a focal asymmetry. Didn't show any enhancement with a high negative predictive value of this technique. It's very unlikely that you have a breast cancer there. But with permission of the patient, I did a very old school compression examination, not a tomo. I really like these old school rolled views and compressions and you name it. And you see that there's no cancer at that side at all. Again, you can have recalls with small, ill-defined or sharply defined masses. And you can see that they're not enhancing, especially in this case, you see a sort of a black hole appearing. And this is what they call the eclipse sign. This is also being recognized by the BI-RADS lexicon. And this is a typical sign of a cyst. It's a very reliable sign that you can use to do a cyst. And you don't need to do an ultrasound when you have experience with looking at these signs. Again, sometimes it can also be surprising. This was a woman recalled for suspicious calcifications in the outtake, but we saw a different tumor enhancing. The calcification turned out to be benign, and we find by chance another invasive tumor somewhere else in the breast that was not recalled from screening at all at that point. Now, we applied the contrast-enhanced mammography in a randomized controlled clinical trial. We compared it with a conventional workup of these women, and we expect the results, which are very promising to see from a cost effectiveness point of view, to be published early or by summer 2024. So I would like to invite you all to keep track of that publication, and hopefully I can share it with you as soon as possible. Now, the next indication is response monitoring and neoadjuvant chemotherapy treatment. Here you can see on the left side the situation before any treatment. I flipped the images a little bit around so they could fit on the slide. And you actually see an ill-defined mass with heterogeneous enhancement, suggesting again central necrosis. And halfway during treatment, you can actually see the volume of the mass decreasing, but also the intensity of the enhancement decreasing. And in the end, there was only a small mass left with absolutely no enhancement there as well. So you can see actually the progression of the response. Now here on this example, we see a woman with a large mass in the left breast. And in the central part of the image, after 4 cycles, you can quite nicely see that the volume of the mass is diminishing, the intensity of the enhancement is decreasing. But in this rather strange case, during halfway of the course and the end of the course, there was again progression of disease. This is very rare, but you can actually see the differences in volume and intensity occurring throughout the cycles of chemotherapy. This was recently summarized by a study by Kalin. They looked at contrast-enhanced mammography and contrast-enhanced MRI in terms of response monitoring. And here again, you see that the sensitivity is 84% with 80% specificity. And when you look at the performance of contrast-enhanced mammography, slightly higher sensitivity with 93%, slightly lower specificity. But you see again, with the exception of some minute details, that it looks to be on par with breast MRI. And again, the only question at this point that the medical oncologist asks is there stable disease, regression or progression? The next thing that we can recently do with contrast-enhanced mammography is contrast-enhanced stereotactic biopsy. We've been doing that in our hospital from October last year. It works very nice. Of course, it's always very interesting to learn any new technique. But for everybody who likes to ask how this works, it's just stereotactic biopsy with contrast. So you can see the similar images that we are used to looking at when we look at calcifications. But now we don't look at mammography images and calcifications, but we look at the recombined images and enhancement. And you can easily put your cursor on that enhancing mass or non-mass enhancement. It calculates your coordinates. You can place your vacuum-assisted needle. And under local anesthetics, you can take the biopsy samples there and place a marker. Again, it's similar like a breast MRI in terms of we take a slightly larger number of samples because we have nothing to really compare. You can check calcifications in your samples. You cannot check enhancement in your samples. So like MRI, we're a little bit on the larger side in terms of volumes when we do these kinds of biopsies. And when you look at the first publication by Rodrigo Alcantara on this topic, you see that the successfulness rate is very high. Unsuccessful is very rare that you have this. Of course, you have the well-known complications that are associated with vacuum-assisted biopsies. But I think the most important numbers is that in their study, they have up to 70% of risk lesions and even higher chance of malignancy. So it looks to be a very promising technique to explore further. Also, regarding the time frame that you have, always a very important question. How long does it take before you can target your image? You can see here from their results, and they're rather in line with our own limited experience up to now. The median is approximately 2 with a range of 1 to 4. That's very easy and very quick to target your lesion and do the biopsy. The time of procedure is again in line with what our experience up to now are, approximately 50 minutes of procedure time. So very easy to perform and not anywhere near in terms of procedure time when you compare it, for example, with breast MRI. So again, it's similar to a stereotactic biopsy, but with contrast. Now, the promising thing is that the results of contrast-enhanced mammography are so promising that in the early years, we are actually not talking about doing contrast-enhanced mammography in screening. Everybody was afraid about the increased radiation dose and the use of iodinated contrast agents. So everybody said, well, it's a nice tool, but we're never going to do this for screening because it takes too much time, too much effort. It's too dangerous on a large scale. But we've come back a little bit from that and seeing the good results that the studies show, especially in higher density breast. More and more study groups are sort of taking the leap of faith to study it in screening programs, even with women with an average risk profile for having breast cancer. There's one UK trial, the BRAID trial, which compares dense breast with automated breast ultrasound and abbreviated breast MRI. There are 2 studies from the United States being planned or even currently under recruit. And we ourselves, the group that worked on the dense trial with using MRI in women with dense breast tissue, we also came together again and we acquired funding to do the dense 2 trial, in which we again do a contrast-enhanced mammography image as an additional examination after a negative dense screening mammogram, and we're going to compare it with abbreviated breast MRI. We expect to start inclusion of patients at the end of the year. So I'm looking very much forward to including the first patient and of course the initial results. So on a very broad scale, it looks good for contrast-enhanced mammography. The image indications are expanding. The more and more units are being installed, more and more people are embracing it. And again, it's not forbidden to do breast MRI. I think breast MRI is a very nice tool. It's always been, but it's rather expensive and its availability is quite limited. So why not do contrast-enhanced mammography where we can do it and save up the precious MRI time for women that are really requiring difficult cases, maybe a large background enhancement, people who are hypersensitive to iodinated contrast agents. There's really a selected population that we can still do sufficient numbers of breast MRI with. But again, a lot of these women can be evaluated with contrast-enhanced mammography in a similar fashion, much more rapid, much more cheaper, and a much easier way. So with that, I would like to stop, and I would like to have a final quote of another very important doctor that you might have seen in movies here and there regarding contrast-enhanced mammography. I think its future is looking very good.
Our future's so bright, we got to wear shades, Mini-Me.
And with that, I would like to thank you for your attention. I give the word back to our moderators.
Thank you very much, Dr. Lobs. This was a fantastic presentation and a comprehensive presentation about CM. If you have any questions, please write it in question and answer box. I have one question to Dr. Lobs. What is your management of microcalcification, suspicious one, in case of you don't find enhancement after CEM? How to manage these cases?
Yeah, we did a study on that, looking at microcalcifications and seeing how they are being, how they look on contrast-enhanced mammography examinations. Well, what we found is that when you have suspicious microcalcifications, so pleomorphic, ductal pattern, everything that you can call suspicious, and it's a BI-RADS 4, and they don't enhance, you still need to biopsy them because you cannot rule out that it's still not a low-grade DCIS or intermediate grade DCIS. However, sometimes you can see some non-mass enhancement overlaying. And in my personal experience, then BI-RADS 4 becomes BI-RADS 5. So you can upscale it a little bit in terms of BI-RADS selection, but you cannot downscale it. So you still need to do a biopsy. But sometimes it can be a little bit helpful to see if there is any enhancement outside of the calcifications. You should be a little bit wary that it's probably bigger than what you see. But it's difficult.
Yeah, I agree. So I have a question from audience. Dr. Melton has a question about the management of BRCA patients over 40 years old. In this case, do you prefer CEM annually instead of conventional mammography? How do you manage this case?
Yeah, the BRCA gene mutation carriers, of course, there's a lot of evidence on that topic that MRI is the preferred imaging modality. We've seen that it's really helpful in detecting breast cancers in this category of often young women with sometimes a higher breast density. I think hypothetically you could have the similar results, but you have the disadvantage that you are exposing these breasts, which are sometimes a little bit more sensitive to radiation exposure, to an increased radiation exposure annually for a lot of times. So it seems to be a little bit unethical to do that multiple times in a woman who is already at risk. We do it right now when a woman has a contraindication for breast MRI. When she, for example, has an implant or anything that she cannot go into the MRI, we think it's a big step back to go to conventional mammography. We do not do her justice very well. So we usually sit down with these patients and do shared decision making and say, well, we have this alternative, but this is the advantage, this is the disadvantage. And sometimes you make a personalized plan with what we feel happy with as a doctor to detect sufficient cancers, but also in which the woman itself feels confident.
Okay, thank you very much for the answer. I'll give the mic to Melis.
Thank you, Giovanni. Thank you, Dr. Lopes, for this nice presentation. And we have many questions from the audience, and I will also ask one of mine with one colleague. You, in your ECR presentation a couple of years back, you mentioned that you hesitate for the invasive lobular cancers, but now you presented that the results are much or less similar with the MRI. Do you still think is it a limitation, or is there any other limitation for this CEM, for example?
Thank you. Thank you for this very critical note that I had another presentation some years ago in which I said, well, you could still do breast MRI for invasive lobular cancers, which was absolutely correct because we didn't have that study yet. When we are writing this review, we noticed that, well, this is a gap in knowledge. Could we reach the similar results in invasive lobulars that we acquire with MRI? So this is the reason why you think up of studies. And then we did a retrospective analysis with my good friends Frank Raad and Timo van Eynatten from the both hospitals. And then afterwards we found that, well, it works as nice. So if I would give the presentation now, my message would be a little bit different, but that's how research goes. You try to figure it out how it works. And again, you should note it's retrospective in design. So it's looking good and safe enough to do a prospective trial on that as well, which I think would be the next step to look at it.
Okay, thank you. And we have one other question from the audience. Can we use the Eklund technique for the CEM for the implants?
Well, in theory, you could do it because the Eklund technique is just a matter of mammographic positioning. Although you can get rid of a lot of the implant in those cases, it's not always that you can get rid of the implant completely, and it's always only in the CC view. So you would still have in many women the artifacts where the implant is a little bit showing on the CC view, and you have a large artifact on the MLO view. So again, this is where I think, well, why not do an MRI? We still have the MRI, and that's a much better technique to look around the implants, and maybe if you want to look at the integrity of the implants as well. So I would still prefer the MRI in that case.
Definitely. Giovanni?
Yeah, I have a question from the audience about future perspective of CEM. What do you think, Dr. Lopes, about the implementation of tomosynthesis in case of CEM? It may add value to the diagnostic role of this technique.
Yeah, I'm a little bit cautious about that because it's always the question: are you doing more of the same? Where does your power lie? Because does it lie in the better depiction of your anatomical structures, so tomosynthesis, or does it lie in the additional information that you get through perfusion, so enhancement? And I believe the latter. I think adding tomosynthesis is making your mammogram better. That's always a little bit of a quote that I still remember from, I believe, Perscade. It's a better mammogram, which I fully agree with. But with contrast enhanced mammography, you're adding next to anatomical information, you're adding functional imaging. So you're adding an extra dimension in my perspective. And I really think that's the additional leap that makes it better. And I don't think that if you have an enhancing mass and then you do a tomo of it and you see that it's well defined and everything, that you can safely say it's an enhancing fibroadenoma, that's, I think, it's a little bit dangerous to do, because the positive predictive value of something that is enhancing is up to 50 to 80%, and then you just need to do a biopsy. Biopsy is easy to perform, it's cheap, so no woman will ever agree that you're going to risk that you're overlooking a breast cancer. So I'm a little bit critical in that. I hope it will work, but I'm critical. And in that aspect, you're doing tomo, you're doing a low energy, and you're doing a high MG. And when you look at those results, you really get close to the maximum levels that are allowed, and also the technical limitations of your system. Your tube will overheat. Your X-ray tube will decrease in quality more rapid. So I'm keeping track of it, but I'm a little bit on the critical side, to be honest.
Okay. So I have another question from the audience. What is your experience with Paget disease and nipple, in case of nipple disease?
With nipple disease, we know from other studies that areas that are difficult to appreciate on mammography are the nipple area region, positions close to the chest wall and the medial part of the breast. So these are also difficult areas to assess when you look at contrast-enhanced mammography. There have been some abstracts on the ECR quite recently with a little bit variable results showing that MRI might be the preferred modality if you really want to look at nipple involvement. But again, these are highly selective cases. If you want to do a nipple sparing mastectomy, that's a very select case, I think. And even if you have a contrast-enhanced mammography and the question in your MDT meeting is the nipple involved because we want to do a nipple sparing mastectomy, then I, as a doctor, would say, I need an MRI to safely answer this question. So in that case, we do an extra MRI. But in all the other cases, we might not need an MRI because that's not the case in those examples.
Okay, thank you very much. Malice, do you have a question from
Yes,
audience?
I will have. I'll ask a couple of questions. One of them is how long does it take for the enhancement to last in order to perform your stereotactic biopsy with SEM? So, do you have any time limit?
I think to visualize the enhancement, the same as a clinical examination, it's up to 10 minutes. But seeing our own results and seeing Rodrigo Alcantara results, that when you have these scout images and you detect the lesion within 2 or maximum 4 image acquisitions, it's never a problem. When you go further down the line and you do your needle positioning check and everything, then you can see the enhancement going down. Especially, for example, if you have a post-fire image check that you do, it's becoming more difficult to see the mass, but you then already have your caliper placed on the lesion. So you already know where the lesion should be. So that helps a little bit. And we always draw lines in the field of view to see whether the patient has not moved in between.
Okay.
That's the practical approach.
Yeah. And also related with this topic, they also ask that what do you do with the contrast-enhanced mammography enhancing lesions if you don't have contrast-enhanced biopsy, for example? Do you do MRI or what do you
That's
prefer?
the answer. You do MR-guided biopsy. In the early years, we did an extra MRI and then see if the lesion was already present there. And then subsequently did an MR-guided biopsy. But we're so confident that most of the times you also see the enhancement appearing on an MRI that we immediately make an appointment for an MR-guided biopsy. And most of the times you see the lesion as well, and then you can do an MR-guided biopsy.
Okay, thank you. Giovanni?
Yes, I have a question from audience. If they ask if you perform always a late acquisition in the protocol.
No, I don't perform a late acquisition.
Okay.
Because it's a little bit difficult. Sometimes you see studies coming up with measuring the gray value of enhancement on recombined image. I think you should be a little bit careful with that because I think it would work within that image. But if you have the different view, you have a slightly different compression. And we know from studies that we did that the intensity with phantom measurements that we did, due to the breast and breast artifact, you saw that the gray value goes a little bit down on the periphery of the breast. So if you have tumors located at the periphery of the breast, the gray levels are already a little bit lower than you would expect. I think there's knowledge to be gained with quantifying contrast-enhanced mammography, but I think it's a little bit more difficult than just measuring the gray values on your PAC system. And in terms of a delayed image, again, that sort of comes close to measuring gray values. The reason why we want to do the delayed image is to sort of simulate the kinetic curves that we use from breast MRI. Then I would like to return the question, why would we want to do that? Because the contrast chemistry is completely different. The contrast volume is completely different. So maybe there's something to be explored, but I don't think we can copy Christiane Kuhl's signal intensity time curves quite easily one-on-one on contrast-enhanced mammography. It's just the basis is the same, but the image acquisition is a little bit different. So I think that's difficult to copy it one-on-one.
Okay. Thank you very much. And another question about CM for radiological follow-up after surgery in case of breast cancer.
Yeah, I think these are very promising results from Spanish and Australian groups. I've seen some published results and some non-published results on that. You could already ask yourself, why are we not doing MRI in these women? Because what I know is recurrences happen in 1 to 2 per 1,000 follow-up examinations when you use conventional mammography. And it goes up to 18 or 19 per 1,000 when you use perfusion-based imaging like MRI or contrast-enhanced mammography. So you could already argue, why haven't we done MRI as a standard imaging modality there? It's probably because these are high numbers of patients, so we have limited capacity. But I think we should really consider perfusion-based imaging in these women. But I think we need to study which women would benefit most, because we could detect lesion earlier, but there are also some studies that advocate that doesn't really influence your prognosis anymore. The prognosis is being dictated by the primary tumor. So yes, there seems to be some kind of information lying there, but I think we should be very critical on which patient should we use this. And in the end, we should do it to the patient benefit. So there should be a survival improvement in these women as well. So anybody who's looking for a research line, there you have it.
Okay, thank you very much. I don't know if Melis has another question.
Yes, some couple of last questions. Actually, questions are coming crazily, and now let's start with this. And do you trust or rely on CEM on DCIA cases, Dr. Lobs?
On which cases? Sorry.
DCIS cases.
Yes, but I use it as additional information. When I have a calcification, for example, if I find it by chance on a normal mammogram, and I already decide this is suspicious calcifications and I need to do a stereotactic biopsy, I don't do an additional contrast-enhanced mammography, because I know if it's not enhancing, I need to do a biopsy. If it's enhancing, I need to do a biopsy. So in the end, I need to do a biopsy. I know some Italian colleagues who are working on a study looking at enhancement in these calcifications and probably targeting the enhancing part of the lesions with contrast-enhanced stereotactic biopsy, hypothesizing that that's where probably the invasive component will lie. So that's a very interesting approach. But right now, for everyday clinical practice, I don't specifically use contrast-enhanced mammography for describing the calcification. There's not really that much more information there. You still need to do a biopsy.
Yes, of course. And also one other question, how do you deal with the high background enhancement for the screening patients?
Yeah, so an often heard question is the BPE, the background parenchymal enhancement. Yes, this can be very extreme. This can be mild, moderate, or non-existent. And if you look at studies comparing it to MRI, you roughly see that in the same patients that have large BPE, they also have it on MRI. And yes, you can do something with the menstrual cycle in day 7 to 14 to have the smallest chance of having BPE, but it's not zero. You reduce the chances of it occurring. Now, with MRI, we did that for many years, but you run into some practical problems. When you have oncologic cases, you cannot wait to the optimal cycle to occur. You need to do your image examination right away. On the other hand, in young women, they often continuously take their oral anticonceptives, or they have an implant on or anything. So they don't really have a cycle anymore that they really can predict where they are. In perimenopausal women, it's irregular. And in postmenopausal women, it's not there anymore. So in the end, we sort of try to let go of this planning based on the menstrual cycle, because we need to reschedule women over and over again. And in the end, sometimes it can be annoying, but looking at the results of the DANCE trial, approximately, I believe, somewhere between 4 to 8%, which was really extreme BPE, which almost made the MRI useless. So it's a very small group that we're talking about, actually. And I expect that with the screening trials coming out, having BPE that makes the contrast-enhanced mammography useless will also probably be 4 to 8% in that order.
Okay, thank you. And Giovanni, do you have any questions?
Yes, I have, I think, the last question because we are almost out of time. I'm so sorry. We have lots of questions. I take my clue from one of the questions from the audience about BI-RADS3 and contrast enhancement ECIM. And I have a question for Dr. Lobbs. If you have experience with management of BI-RADS3 lesion after the vacuum-assisted excision for the follow-up with contrast enhancement mammography.
Well, I read an interesting paper quite recently by Rubio, I believe the first author was, giving a quite nice overview from a surgical point of view, but also an imaging point of view, what to do with these high-risk lesions. There's a very small amount of evidence there regarding the use of contrast-enhanced mammography, but also MRI, should we do it? So, because it's very difficult to get sufficient numbers of those women to really have good results or good conclusions regarding your study. But in general, you see there that if you have a true benign lesion, then it's okay. If you have some suspicious characteristics like atypia or anything like that, they always suggest that you excise it. Sometimes the recommendation is to use MRI or contrast-enhanced mammography, because they argue that if it shows no enhancement, then you could consider a short-term follow-up. But from a practical point of view, if you have a high-risk lesions with suspicious characteristics like atypia or anything like that, I would just recommend to do a surgical excision or a vacuum-assisted excision, which is also very new and exciting technique to do. And I think that's the safest approach that you can do because of the lack of knowledge, to be honest.
I agree. Okay, thank you very much. So, Malice, I don't know.
Okay, I think maybe with one last question we can finish, and I can see that you still have some questions, and we can ask Dr. Lobbs if it's okay with email, and we can we can share with you some of the answers, because audience is very keen to know about more than with CM. And it is my last question. Sorry, it's what about your false negative results, Dr. Lobbs? Many people ask this.
Yeah, there, of course, in every examination there are false negative results as well. The pitfalls, I think, in contrast-enhanced mammography are invasive lobular carcinomas. They remain challenging also on MRI, on mammography, and also on contrast-enhanced mammography, especially when they're small and very difficult to see, because we worked together with Timo van Nijnatten on a study showing that these often show no or very weak enhancement. So they're difficult to detect. The same goes for mucinous carcinomas. They have a lot of aqueous content in themselves and only a little amount of vascularization and viable tissue, cancer tissue. So they also tend to show a little bit less enhancement than that we're used to. And of course, sometimes you can overlook a DCS, but then it's not the problem of the contrast, but you just overlooked the 3 millimeter calcification. So we have these cases as well. And I don't think that's the problem of the enhancement. That's the problem of just overlooking on the mammogram anyway. So these can occur, but I think you should be cautious about small invasive lobulars and mucinous carcinomas. They can show no enhancement or very poor enhancement.
Okay, thank you, Dr. Lobbs. With this, I unfortunately have to close the session, and thank you again for this extraordinary, nice presentation. And we have two announcements for the next webinars. One is the postponed webinar from 2023, which will be on 10th of April on brain metastasis imaging, treatment and post-treatment. And the next one?
The next one on 18th of April about fundaments of breast ultrasound, basic and beyond. So please subscribe to these fantastic webinars.
Yes, don't forget to follow us, and please don't forget to fill the survey form to claim your CME. And thank you for tonight. Thank you, Dr. Lobbs. Thank you, Giovanni.
Thank you.
Goodbye.
Thank you, everyone. Thank you,
Bye,
Dr. Lobbs, and
everyone.
thank you, Melis. Bye.
Thank you very
Bye.
much. Bye-bye.
Bye. Thank you.